Good morning. I'm going to get started just a couple minutes early with housekeeping announcements. We'll wait till the time for the formal introduction. Good morning. My name is Janelle Gagne. I'm one of the planning committee members for this year's spring clinical, and I'd like to welcome you to our Kopple Award session. But prior to that, we do have our housekeeping. I think by now all of you have downloaded your app so that you can do your pre and post questionnaire and your evaluation. All are required to get your CEU credits. I'd encourage you to do them while you're here, while everything's fresh in your mind. I think that'll be a lot easier. Our speaker this morning's slides can be found on the app as well if you want to follow along, or certainly we have the big screen here. Be sure to share your experiences on social media with hashtag NKF Clinicals. And finally, if you don't call us your professional home, we hope that you do so because you can get lots of good member benefits and discounts for our meetings. I want to put in a plug for a new session that we're having later today. It's at the very end of the day at 4:30 called Chat with the Experts. It's a networking event where you can literally sit down with an expert of many topics and just have a 25-minute conversation about practice and help you with maybe some of the issues you're having in your practice. So please join us for that. And then finally, all day yesterday, I know you heard about the dietitian survey that's available. A colleague of mine will be passing around QR codes if you'd like to help us with that. We're trying to do some research and take a look at salary, ratios of patients to staff, burnout, satisfaction, that sort of thing. So we'd appreciate it if you could help us with that. And now we're at the hour that we need to start. It is my distinct honor and privilege to introduce our 2026 Joel D. Kopple Award winner. For those who may not be familiar, the Joel D. Kopple Award is given annually to honor an individual who has made significant contributions to the field of renal nutrition. Like Dr. Kopple, the recipients of this award are not only giants in the field of renal nutrition, but serve as mentors to all of us as we work together to care for our patients and further our profession. I see previous recipients of this award in the audience and know that you all continue to do great things and serve as mentors to all of us. This year's recipient of the Joel D. Kopple Award is Dr. Mona Calvo. She's an adjunct research professor in the Renal Division at the Icahn School of Medicine at Mount Sinai in New York City, where she collaborates with Professor and physician Jamie Uribari, who's in the audience with us today. After retiring from the FDA with 29 years of experience in food additive regulation and dietary supplement safety, she continues research linking nutrient imbalances, specifically excess phosphorus intake and vitamin D deficiency, to endocrine issues, bone disorders, and kidney disease. Dr. Calvo was among the first to expose hidden phosphorus in processed foods and advocate for its mandatory labeling on processed food labels, as well as the need for increased vitamin D fortification of eligible foods. Her work has influenced nutrition science through over 100 publications and over 14,000 citations. She serves as deputy editor for Public Health Nutrition, which is published by Cambridge University Press on behalf of the Nutrition Society. She's an associate editor for Applied Physiology, Nutrition, and Metabolism, published by Canadian Science Publishing. She's a review board member for Osteoporosis International and a reviewer for many major nutrition journals. Once again, I would like to congratulate Dr. Calvo on her well-deserved recognition via the Joel D. Kopple Award. On behalf of myself and all renal dietitians, past and present, I want to thank Dr. Calvo for being one of our greatest champions with respect to phosphate additive concerns and invite her to the podium to share with us her current thoughts on the topic. Her presentation is titled Phosphate Additives and Ultra-Processed Foods, a Mechanism in Cardiorenal Disease. So, welcome, Dr. Calvo.
Thank you. Good morning, and thank you all for coming so early. It's nice to see you all. As Janelle said, I'm going to talk about phosphate additives that are specific.
Okay, we need to adjust the mic.
Oh, thank you. Phosphate additives that are specific to ultra-processed foods, and explore whether or not this could be a mechanism operative in increased risk for cardiorenal disease. I have no financial relationships, unfortunately, with ineligible companies, but I guess that's a good thing. So I'm going to give you all my learning objectives in one lump sum, but then I'll go through each one separately as we come to them in the talk. So initially, I want to define and characterize what ultra-processed foods are and look at what the intake is. And it's linked with adverse outcomes, these being mortality, type 2 diabetes, CKD, and cardiovascular kidney metabolic disorder. And all this with a focus on phosphate additives. And in the second learning objective, I'm going to identify barriers to accurately quantify phosphate additive use in ultra-processed foods and describe some of the postulated mechanisms related to ultra-processed food phosphate additive risk, and show you a new way to estimate population phosphorus additive exposure in the foods we eat. Lastly, we'll go through and hopefully recognize the potential harm to CKD and other diseases with high intake of ultra-processed phosphate additive food categories. We'll look at dietary guideline issues and introduce a new labeling strategy that we've come up with that's in progress to reduce current excessive total phosphorus intake. So our learning objective 1, what I'm going to go through is first introduce you to the NOVA classification of processed food. We're then going to look at the high ultra-processed food intake that's linked to chronic disease risk, especially that of CKD and premature mortality. And I'm going to show you how researchers identify ultra-processed foods. And lastly, well, why am I focusing on phosphate additives in ultra-processed foods? So the NOVA classification that I'm going to talk about really arose in the last decade when the United Nations declared the decade between 2016 to 2025 as the decade of nutrition. And during that time, there was a paradigm shift in what we call a nutritious food. This involved going from emphasis on nutrient content to the way and purpose we process food. Now, the NOVA classification was developed by Carlos Monteiro, who is a Brazilian. And he named it NOVA, meaning that it's new. It's a new way of looking at food healthiness. Also, he wasn't thinking in Spanish because Nova in Spanish means no go. So I find the use of that title to be somewhat questionable. Anyway, what it does is it classifies foods into 4 categories, and they're based on the extent of processing. And they range from most healthy, which is group 1, to the least healthy, which is group 4, which are the ultra-processed foods. So this is the most widely used system globally. However, there are a lot of other classification systems that have been developed. All of these, including NOVA, have their shortcomings, but we're going to talk about NOVA today because it's the one most people use. So this gives you an idea of what the foods are in each one of these categories. So they're grouped as, group 1 is minimally processed, and you can see that these are foods, basically you can classify them as whole foods. Group 2 are the foods that you would use to prepare foods in your kitchen, commonly used culinary ingredients like butter and seasoning and salt. Group 3 is processed food, but it is lower levels of processing. So this is canning, baking, but it's home baking or baking from a bakery, but not industrial type of baking. The last group is the ultra-processed group, and these are foods that are industrially formulated, usually brand name food, and they contain additives. So, and ultra-processed products are made from things that are not usually found in your kitchen. And these are things like hydrogenated oils, hydrolyzed proteins, high fructose corn syrup, etc., that are used in industry. Now, if you look at the bottom arrows here, you can see that there's a continuum between healthiness and least healthy, with the highly industrial processed foods being the least healthy and the processed foods being the most healthy. So this gives you a pictorial view of what these foods are. So in your head you can classify them very easily. Number 1 being whole foods. Number 2, the processed culinary ones. And number 3, we can see the processed foods. And 4 are all the foods we love to eat, and the most delicious ones. So what is the issue with group 4? Didn't advance. Uh-oh. Can I go back? Oh. Yeah, that's, oh wait, no, that's not the.
That's not the right one?
Yeah. Oh, no, it should be. Yeah, that's it. Thank you. I'm sorry. So let me show you this in terms of one product, and this product relates to potatoes. So the potato under the 1 group is the minimally processed, and this is a baked potato that you do in your own oven. The culinary ingredient needed for processing is a slab of butter that's on the top. So number 3 is processed, but this is not extensive processing. In this case, these are frozen vegetables with an organic label on them, so there's a touch of sea salt in them and nothing else. But it's the last one that we all favor, and this has a great deal of processing. So it is minced potatoes and has a lot of additives added to it. So now you know what ultra-processed foods are. So let's look at how much we eat. So in America, we have the highest intake along with the Brits, and the Canadians are not far behind. And these values, the bars are adjusted for percent energy intake, percent caloric intake. And you can see that Americans consume, on average, between 50 and 60, and now up to 70% of our calories from ultra-processed foods. And we've been doing this for a long time. These are data from the NHANES surveys, and they show that we've had a continued high intake, between 50 and 60% of our calories. If you focus on the purple lines on the top of both panels, A and B, you can see that the ultra-processed food consumption has continued over 2 decades, and there is no difference in race, ethnicity as far as consuming them. Neither is there a difference in the intake by family income. So it's the majority of people that we're looking at. So why all this hoopla over this? Well, there's been an extensive amount of epidemiologic research that has looked at various disease risks in relation to the number of serving sizes consumed that are ultra-processed, as shown in this slide. This shows the relationship, the increased risk from consumption of greater than, in this case, you can, if you look up from the x-axis where the 5 servings per day, you start to see significant rises in risk. And this is all energy adjusted that they're taking into, and this continues. So this is just one example of hundreds now that we have, and the data is becoming overwhelming. Here's an example with CKD risk taken from the Crick study. Now, here we have similar, you see the inflection point. Oh, I don't know if the laser will show, if I can show that. Your inflection point here, again, is just over 5 servings per day of ultra-processed food. And so there is risk with a lot of other diseases, type 2 diabetes, now cancers, and I won't go into elaboration, but just know that this isn't even the tip of the iceberg. There are so many studies that are confirming this, and most of them done with the NOVA system. So how do we tell what food is an ultra-processed food and what is not? Well, this is a very simple way to remember it from Montoya's work. Now, here we have 2 categories, and Montoya's opinion is that you need only to have one of these elements from your on your food for it to be classified as an ultra-processed food. So that is a component that's part of the food substances that are rarely used in kitchens, or additives that belong particularly to 12 different classes. Now, these classes are marker classes, as he describes them, but they're functional classes, that how we would identify the use of a particular phosphate additive, or any additive for that matter. So what are the possible mechanisms? Because my emphasis is going to be on phosphate additives. Well, if we look at the substances rarely found in home kitchens, we know that they are probably associated more with dyslipidemia, glycemia and insulin resistance, hypertension, and obesity. But the additives, particularly phosphate additives, would be more likely to be associated with mechanisms coming from oxidative stress, inflammation, disruption of the microbiome, or endocrine regulation and vascular calcification. So let's get in deep with phosphate additives. So something my kids refuse to listen to when I talk about them. So the convoluted FDA definition of an additive or an ingredient, as the FDA likes to call them, is at the top. But let me simplify it for you. An additive is just something that's added to food in order to industrially process it. And that's a very simple way of looking at it. So for your information in the future, I've listed sources of phosphate additives that you can look up, all located in the FDA's web sources of information. But I'll classify them for you. Generally recognized as safe is or GRAS is probably what most of you are familiar with. And there are 45 of those that were given GRAS status back in 1970s. The other ones have been brought in as GRAS status, and all of these are listed under substances added to foods. This was formerly known as EFS, or everything found in the U.S. food supply. So there's 54 of those. Then this is a category that you're not familiar with, I'm sure, which is the USDA's FDA additives that are allowed in organic, agriculturally processed foods. Now, most of you are probably thinking, oh, if I eat organic, it doesn't have any of this stuff in it. But that's not the case. There are 7 phosphate additives that are allowed in organic products. So, and then there's the GRAS notification, which is in progress, and I don't have an update on the food additive status list. So, why am I so keen on looking at phosphate additives other than their relationship to CKD? Well, that's because there's so many of them. And this just gives you a flavor of the GRAS substances that are commonly used, 49 of them. And you can see that all of those shown in black font are inorganic. They're phosphate attached to usually some cation, which can be calcium, iron, potassium, or sodium. And the ones shown in orange are ones that people are less familiar with. These are the organic phosphate additives. And they're organic because they're attached to a carbon molecule. And these are what we commonly call, with the exception of lecithin, these are the modified food starches that are on the ingredients list that nobody knows what they are. So, in order to have a food additive lawfully added to the product that you're making, it has to have an approved technical function. And these are the 32 technical functions that the Food and Drug Administration lists that you have to go through the procedure of finding out whether your product is suitable for this or not. So, of these 32, phosphate additives can be classified in 26 of them. And the number of approved phosphate additives in each of these major technical functions differs. And as you can see from number 2 and number 3, these are both classifications of those markers that I showed you earlier. So as many as 24 phosphate additives can be used as a stabilizer, 20 can be used as emulsifier, etc. And so you can have multiple phosphate additives in a product legally, and they would, so there's a cumulative effect. And as an example, I show you here lecithin. Lecithin is probably one of the most highly used of all, it is the most highly used of all the phosphate additives. That's phosphatidylcholine. And you can see 10 functional classes that it belongs to. So it's found in so many ultra-processed foods. So this just gives you a quick glance of all of the phosphate additives that can occur in the products that we like to eat. These are delicious. So, maybe the phosphates make them so. So let's get on to learning objective 2. So I'm going to talk about the barriers that you all especially face in trying to determine the phosphate additives and the total phosphorus that are in ultra-processed foods. So this is the absence of labeling, underestimation of intake, and no exposure data. Then we're going to look at mechanisms of CKD risk in high phosphate additive ultra-processed food intake, and methods to determine ultra-processed food categories that are linked to type 2 diabetes specifically, which, as you know, is can lead into diabetic nephropathy. And last, we're going to deal with novel methods to estimate what our population is exposed to in terms of the phosphate additives in foods that are on the market now. So the first one you're all familiar with. The Food and Drug Administration updated their nutrition facts panel in 2016, largely to the benefit of the public, but not to the benefit of CKD patients. And let me just outline some of the misleading concepts for CKD patients and dietitians. First is the daily value that's used to indicate a food guide of intake that you need. This was changed in 2016 from 1,000 to 1,200, to 1,250. So if you're a CKD patient and you're looking at the percent that you need to take, it's really a much overestimation of what you need. So the nutrition panel does not help you. So they did some good things other than refusing to. They refused to put in phosphorus content on the label, which was asked for by NKF and many, many others. But they have mandatory labeling for other things that we need, like D and potassium, calcium, iron, and they show it by weight and by daily value. So we have a real problem with the ingredients list, because the ingredients list can be very confusing, because there's a number of additives that are very commonly used, such as the modified food starches, but you don't even realize that they contain phosphorus, but they're listed here. And again, the common use of lecithin, phosphatidylcholine. And others are sometimes abbreviated. So this can be highly confusing. So the second big issue is underestimation of ultra-processed food, the total phosphorus intake. And that's a problem with the accuracy of the nutrient databases. And I show you here just a sampling of all the studies that we've looked at that have verified this underestimation. And there's a really large range, but it all comes back on average to the values that we found very early on in 1988, looking at direct analysis versus the uses of the nutrient content softwares. And this range is about 25 to 30% underestimation. And this gives you an example of that kind of underestimation from which I think is now a pretty famous study that was done at the Cleveland Clinic. And this shows the differences in actual phosphorus content from the nutrient databases. On one product, they went into a grocery store in the Cleveland area, and they picked out all the chicken breast related products. There was 34 of them. And they did both the analysis via the software, and they did direct chemical analysis. And the values that are negative, shown at the top, these are 3 products plus one from the other column that have negative values, that there was no underestimation there. That was, but they also contained no phosphorus additives. So the number of phosphorus additives that were contained are shown in parentheses with blue font. And all of those that had multiple phosphate additives had consistently underestimated the amount of phosphorus that was in the product. So this can be very misleading, because this is expressed per 100 grams. But if you're eating 300 grams of a product that really has 165 more milligrams of phosphorus in it, that adds up, and that can be critical for a CKD patient. So the other thing we have to warn about is additive use in the plant-based meat and milk alternatives. And this is important with the big push to eat more plant-based foods. But understand that most of these products are ultra-processed. And if you can read the teeny tiny font at the bottom of this label, you'll see that it contains several phosphate additives. So this brings us to barriers that we're all faced with in order to get regulatory action taken upon. And that is, you need to not show just an association with phosphate additives. You have to show a direct connection, and this is causation. So it has to come from intake, and we use the National Dietary Surveys to determine that. But there's a lack of accurate information from these surveys, and because of underestimation, et cetera, and just no knowledge there. So we don't know what the additive content is, and we don't have a good value on the natural content. So, as I said before, in order to do safety testing, you have to show causality with intake. And at this point in America, we can't do that. And this is also important because we can't show the relationship, causation, with excess phosphorus intake in CKD and CKM that will allow us to do some policy changes. So what are the mechanisms that we're looking at? So look at the ones shown in green bubbles. So here we're just concentrating on the phosphate additives. And we know that they're involved in oxidative stress, inflammation, and changes in the microbiome. But today I'm going to concentrate on endocrine dysregulation. These are the hypotheses that Dr. Uri Abari and I have been working on for some time. So this is an overview. There are multiple diseases that are associated with excess dietary phosphorus intake. But here we're going to concentrate just on the black arrows. And this is an endocrine overview, if you will, just to make the explanation a little simpler. And what we show here, if we start with the black arrows, an elevation in plasma phosphorus will cause a direct increased secretion of parathyroid hormone. And that, in turn, working with the elevation of phosphorus, will stimulate in osteocytes in the bone the production of FGF23, which is fibroblast growth factor 23, a phosphatonin. This acts to then ultimately decrease kidney phosphate excretion and synthesis of the active form of vitamin D, which is calcitriol, disrupting homeostasis of phosphorus. In addition, it acts with high levels of phosphorus at the level of the heart and vascular tissue to cause increased calcification and hypertension, inflammation, and atherosclerotic plaque, again increasing CKM. Now, the calcitropic hormones are not, we speculate, as much involved in the phosphorus stimulation of disruption of the insulin, or causing of insulin resistance. And this is more likely related to oxidative stress and inflammation. So what's the major principle behind why phosphate additives are acting the way that they are? Well, it has to do with their structure and their nature and their bioavailability in the body. So plant-derived phosphate is the slowest absorbed, largely coming from phytate, and it has greater accessibility if it's processed, but still it's slow to absorb and is less efficient. animal-derived protein, phosphorus, has also a slow rate of absorption because it has to be enzymatically cleaved, but it has about a 60 to 70% absorption. However, the added phosphorus, this is usually an inorganic salt, rapidly dissociates and is rapidly absorbed and has about an 80 to 100% absorption efficiency. So it's highly available. So it gets there first, as we like to say. So in terms of the mechanism for CKD risk, as we've postulated, is that there is an excess intake of phosphorus, which is due to increased phosphate additives with processing. So this causes an increase in the extracellular fluid of phosphate, which directly stimulates, this is Slatopolsky's work, of parathyroid hormone. And in turn, the parathyroid hormone will stimulate the bone to secrete FGF23 as well as increase bone resorption. But it's the FGF23 that seems to be the key player here. And it eventually will inhibit parathyroid hormone and inhibit its action on the kidney and inhibit its action on kidney synthesis of the active form of vitamin D. It overpowers that and continues to inhibit the NAPI 2A and 2C transporters, decreasing urinary phosphorus excretion and building it up, resulting in the calcification and other things that you've seen. So what evidence do we have? What empirical evidence do we have that these calcitropic hormones are involved in these mechanisms that I just showed you? Well, there's a ton of rat evidence. I show one very well done study here that shows that high dietary phosphate will, and that's usually a salt load, causes both bone loss and it causes increased aortic vascular calcification, as you see by the values in the round circles. So I'm going to show you some very old data that I did back in the 90s, last century. So this is the way that we didn't even know the name ultra-processed food at this time. But what I looked at was common grocery store foods that we carefully selected out, and we knew that they had phosphate additives in them because I was interested in this way back then. And so this is a human study in very young adults, as young as we were allowed to study, and these are circadian studies. So they're over a very long period of time. So they ate all their meals, etc., in the GCRC. So, and this was done over 2 4-week periods. First with a control diet, and then with the high phosphorus food. And these foods were matched. So at the end of each 4-week period, at day 28 and ultimately day 56, they were brought into the unit and studied over 24 hours. That's what a circadian study does. And the reason being is because way in the past, in the 1960s, Nordine and others looked at it and said, you can't see dietary differences with parathyroid hormone if you just do one single sampling because of this circadian variation. So, long story short, what we did see is a persistent increase in parathyroid hormone with a high phosphorus, low calcium diet that reflected the typical diets of these 20-year-olds. So, but the control arm showed no difference. If anything, it improved. And in addition, what I'm not showing here is that we saw a marked decrease in calcitriol synthesis, which one would expect with a low calcium, high phosphorus diet, that calcitriol would be stimulated because that's the homeostatic mechanism. We had never heard of FGF23 back in 1990, so that wasn't part of it. But others have looked at this and show really good empirical evidence. And this is a more recent study that was done by people that originally came out of Hopkins and worked together, Miles Wolff and Orlando Gutierrez. And they did the opposite of what we did, and they looked at it in both normal patients and in CKD patients. And here, what they did was they fed them first a high phosphorus diet for 2 weeks, and then they switched to a low phosphorus additive diet for 6 weeks. And then they looked at the levels of parathyroid hormone and FGF23. And remarkably, the FGF23 went down in the CKD group and in the healthier group, in white adults only, and the parathyroid hormone went down only in the CKD group. So we have very good empirical evidence that these hormones are working in response to high phosphate additive intake. So there's another way of looking at the effects of high ultra-processed food intake, and that is looking at cohort studies. And the study I show here is from the nurses' studies in the Harvard people. So what they did was, these are studies over time, and there's lengthy follow-up, and they looked to see whether or not it was the category of food, the type of food that people were eating, that would increase the incidence of type 2 diabetes risk. And indeed, it was related to specific food types. And these are shown here: ultra-processed refined breads, animal-based meat products, ready-to-eat meals, convenience foods. They are sauces and spreads, which are interesting, and certainly artificial sugar-sweetened beverages, which have shown all of the cohort studies that have been done, which are quite a few right now, have shown this, that these to be the highest. So this has been confirmed. So we got it into our heads that maybe these particular food types are also high in phosphate additives. So we conducted a study. Oh, I think I'm missing a slide here. Yeah. Yeah, that's it. So this is a study we did more recently. As I said, we postulated that the food categories that were significantly associated with type 2 diabetes incidence likely contain these additives. And it could be a potential mechanism contributing to type 2 diabetes. Now, the way that this was done was we used register tapes from household purchases across the United States, very well represented. And these are translated by Euromotor Passport, and this is all magic done by Elizabeth Dunford. So that's transferred into a program called Labels Insight, and that identifies the food category, and it scans the label for its ingredients. And so what we found out that of the top categories of food that were sold in the United States, we are showing the next slide, there was about 40,000 processed foods that we examined. 56% of these contained phosphate additives, and the highest percent of phosphate additives were observed in type 2 diabetes risk foods. Now, I show the ones that we are focusing on here, but we've also looked at the beverages, but those are in other papers. So again, the refined breads, these are industrially produced breads, they were 86%. and 88% of sales. The processed meats and seafoods were lower, was 50% of them had phosphate additives, but 59% of sales. And the ready-to-eat meals were 70%, with 71% sales. So the mechanism of high phosphate additive consumption that we hypothesized is that it increases phosphate intake, promoting oxidatives, stress, inflammation, all known to be underlying mechanisms in type 2 diabetes risk. So this is guilt by association. So on to the last objective, and I'll go through these really fast. Again, I'll show you how we use package labeling to estimate the phosphate additives. And early NHANES work that looked at total phosphorus intake and all-cause mortality, which has been a motivation. So, and some work in progress that we're doing that's not ready for prime time yet, but I'll show you a little bit of what we've done so far, which is to adjust the total phosphorus intake in order to estimate total phosphorus intake plus phosphate from additives. This is statistical manipulation and how they're linked to mortality. And last, we'll go into what some of the novel strategies are. So this is what I just explained to you a little bit ago. And that, I'm just going to go over what the top individual additives were that were found in these ultra-processed foods. The top one, again, as I said before, is lecithin, phosphatidylcholine, and it was found in 32% of the products. Sodium phosphate was next in 13%. Calcium phosphate, used as a nutrient supplement or addition to food, is 11%, and modified food starch is 10%. But it only has one function, and that's as an emulsifier thickener. And again, sodium acid pyrophosphate, which is a leavening agent, and it's found in so many baked goods, especially industrially produced. So 56% is pretty overwhelming to find that much in the foods that we know we're eating, or presumably we're buying it, so we presume we eat it. So this is data conducted by Alex Chang back in 2014. And here he's using that very early NHANES data, NHANES 3. And this represents just total phosphorus intake from the nutrient databases. So we know, number one, it is an underestimation of what we really eat. And again, it had no accounting of phosphate food additives, which garnered some criticism from certain people. So what he found is really important, because he showed that looking at these data at an inflection point right at 1,400 milligrams of phosphorus intake, which is very common, close to the mean of what we consume, is where you begin to see an increased association with all-cause mortality. So this is very interesting, but we think it needs to be looked at again, where we can also look at what the changes occur that would be coming from phosphate additive addition. So this slide is just an artificial mock-up of what it could be. So remember I told you there's an estimated 25 to 30% underestimation. So we took data from the NHANES survey 2013 to 2016, and we added back to it 25%, which is conservative. And this is shown by the lighter colored arrows. The darker colored columns show for men and for women what the intake was at that particular percentile of the population. The lighter colored ones show what it would be like if we took in that 25% as an underestimation of phosphate addition from additives. So if you can see the green arrow, the green column, represents the estimated average intake, required intake, and the light blue line column is the RDA. You can see we far exceed what we need with intake, and this is the normal population. And if you take a mean of the values for men and for women, it comes out to an average about 1,750 milligram per day intake, which is really getting up there. That would be at the 50th percentile. So we tried to use NHANES, or we are in the process of looking at NHANES data to develop a novel proxy estimate of total phosphorus exposure from phosphate additives. And this would be natural plus added phosphorus. And we're trying to, again, explore the association between all-cause mortality using the entire NHANES data, which stretches from 2003 to 2018 with eligible data in it. And this is a complex statistical procedure, which I'm not going to go into, but it relies on residual analysis. And we show the preliminary data right here, but I caution you, there are problems with incompletely adjusting for confounders in the adjusted Model 3. But for all of them, you do see an increase in the hazard ratios of these products. And the people that were deceased with follow-up had a significantly higher phosphorus intake than did individuals that were the survivors. So we're still working on this, but this is just one method that I wanted to show you that we can try and, for now, get a better handle on this, because we're trying to create overwhelming arguments for changes in policy. So what can we do about this? Well, what we've been proposed, or are proposing, is to look at a point of purchase front of package label initially, establish that. Currently, the FDA are examining the benefits and proposing the use of front of package labeling for the general population in order to make healthy food choices. And I show you an example of this here. But attached to that, for the kidney population, we want to have an easily recognizable logo, which is the kidney with the check in it that we're proposing, so that you can see this on the label and recognize that it's gone through muster of being able to support a healthy choice. So in closing, I'm not going to make any conclusions because we're not ready to make conclusions yet. But I want to thank the team I work with, because I'm not a renal dietitian, but I work with people that have been reinforcing this. Our team leader is Dr. Jaime Uribari. I work with Elizabeth Dunford, who is Australian from the George Institute, who is familiar with doing cell phone mobile apps that we hope to apply the front of labeling to. the front of package labeling too. And we work with Katie Tucker, who is an emeritus distinguished professor of nutritional epidemiology, familiar with all the Ian Haynes work, and Liam Fouet, who is a biostatistical assistant professor at the same institution, University of Massachusetts at Lowell. And with that, I'd welcome questions, or do you want to, shall we start administering the?
Yeah, I will. You have quite a few questions, so so yeah, we'll do as many as we can in the time that we have. So I'll just start at the top. What do you think is the barrier of having phosphorus on the food label? Could it be cost?
Obstinance. It's the Food and Drug Administration is hesitant to put any more barriers to the food industry, and I would say that's really the main issue. Also, it would require a tremendous amount of work on their part to justify it, and cost is the other issue. Also, you are probably very much aware that there is no longer a Center for Food Science and Applied Nutrition. It's been Doge dissolved, and there's a rearrangement, and so there's a time element there. And as Kelly Picard pointed out to me, which I was shocked at, that there's really some questioning about the values that go on those labels. She was reporting that that in Canada they found out that there was great inaccuracy in what manufacturers were claiming were in it, and so there's not a staff to check those values either. So I think it's better to take action with saying, we're going to do what the American Heart Association has done, and we're going to warn our patients as to what foods are good and what foods aren't. You know, right on the label. So.
Okay. Thank you. Next, are all modified food starch and modified cornstarch actually phosphorus additives?
Yeah, and that's the most confusing thing, because you can't really tell. But there are different types of starch bases, and that's what the corn represents, that are acylated or phosphorylated or whatever they're doing to them. So that's the difference. But I think it's fair to assume that, yes, they are phosphate additives and contributors. Now in Europe, there's a whole mess more that they've now added, and they use, oddly enough, more than we do of the modified food starches.
Okay.
But they give their specific names. They don't give the confusing name.
Next question. Are there practices from countries with low ultra-processed food consumption that you think the U.S. could adopt in our societies or regulations?
Well, let me put it politically safely. In America, we have a very different system than the rest of the world uses. The rest of the world uses what the European system. And the Europeans use far less additive ingredients in their foods than we do here in the United States. In the United States, we use about 10,000. And they have different rules that they apply to them, in that they have limits of addition. With the grass substance, the limit to addition is what we call good manufacturing practice. And that translates, if it doesn't alter the taste or the way people accept it, you can put in as much as you want. So it's left up to the manufacturer. And of course, there's multiple choices that they can use too. So the Europeans have a much better controlled system than we have in the United States.
Do you suggest any app for phosphorus label checking?
Say that one again.
Do you use any app for phosphorus level checking?
We hope to, yeah. And so what we're looking at is going to be a very different system than what's used now.
Okay. Would you ever do a study on how much phosphorus binders bind to these ultra-processed foods?
That's up to you guys to do. But that's a very good idea.
All righty. Do you know how much phosphorus, as far as milligrams of phosphorus, are in modified food starch and lecithin? And are they as highly absorbable in that 90 to 100% category?
That's something that hasn't been looked at empirically because most people are interested in the choline absorption, a nutrient. But that would be interesting to look at. It doesn't have, I think it would be dependent on how much of it is used, and it's found in so many different places, but it hasn't been looked at yet.
Okay. Let's see if any more are coming in here. I'll do a last refresh. Okay, one last question. Historical studies use supplemental phosphorus to represent high phosphorus diets. Do modern studies actually use food sources to better represent reality?
Well, the two that I showed you was one in the last century that used food. All that food was purchased from grocery stores, and in both the control and the other, and in the Orlando's study, that's the University of Alabama Medical School, they did again, it was food additives identified in foods. So those are the main food studies. But most of the studies that you see are done with bolus loads of phosphorus, which in my opinion, it does not reflect food. It doesn't necessarily reflect absorption. It doesn't affect tissue distribution or a lot of other things because there's matrix interaction. And that's why in order to show causality, you have to look at this with the use of foods that we commonly consume.
Wonderful. Jennifer, I'm sorry. Are you done?
Yeah.
Okay.
Yes.
Go ahead, Jennifer.
Hi, thanks so much for this presentation. Quick question.
I'm sorry, I can't hear you.
Yes, let me try again. For the Miles Wolff study that you showed, and they looked at non-CKD changes in FGF23, it looked like the African American population had no change when they switched to the low phosphorus diet. Do you, or did they mention why that may have been?
No, but that was one of the surprising things. I didn't mention that because race is another confounder that, but no, that was a very surprising thing that they found. But also, there are differences in parathyroid hormone between African Americans and others in that it can be higher, but it doesn't seem to be active in terms of bone resorption. So, because they have much higher bone density. And we don't understand that. I'm speaking with my bone hat on, so from my background. But that was a very interesting finding. So there's a lot of questions still between the interactions between PTH, FGF23, and calcitriol. So,
do you think it has any implications on increased risk for cardiovascular, mortality, diabetes, when we see different races, including African Americans, being at higher risk of those, but maybe it's not from particularly phosphate as an additive, but another additive, or just those other obvious risk factors that, like obesity, hypertension, things like that?
I mean, that certainly has been looked at in terms of ultra-processed food intake with hypertension, but not specifically with food. It's been looked at with phosphate bolus, deliveries, et cetera, but not with food.
Gotcha.
So
Cool.
Researchers tend to stay away from looking at whole food consumption, and which is sad because we eat whole foods. We don't eat bolus loads of salt or, phosphate or potassium, etc.
Thank you.
Okay, one last question, and then we'll conclude.
So yes, I grew up in a time, 70s, 80s, by the way, when phosphorus was on the nutrition label at the time. And as the food marketing really skyrocketed, 90s, 2000s, and they done away with the phosphorus on the nutrition label, and all these, additives being added. It was always my assumption that it was getting out of control, and that's why it's kind of difficult to assess how much phosphorus is in, processed foods. So thinking of when educating our patients, what would you say in the patient-centered education regarding the food labels? Like the number, if there's more than 1, 2, or 3 additives, the increased phosphorus is higher. What would you say?
Well, by law in the United States, if phosphate or any kind of additive is in the food, it has to be listed. But here's the problem. Phosphate additives can be used as formulary preparations, and those don't get put on the label because the step before, they don't know that, so they just take it and just put in the ones that they use in the last step. So formulation aids, processing aids don't, and they're highly used, and so that doesn't get into it. So, it just would require accurate, precise chemical analysis by manufacturers. But these would be manufacturers that would want to have a kidney logo on their package, and off the bat, I can think of several things that would qualify for that. And so that's hopefully what we hope to bring into that. And then depending on how much of the panel you want to cite, how much potassium, et cetera, we'll work that out as to what's good for the patient. And ultimately, we want to put this into a phone app that patients can use by using the QR code, and like you do with glutenopathy and some of the others.
And what's the timeline for that?
Oh, don't ask.
Thank you.
Yeah.
Thank you.
Thanks, everyone.